Welcome back to the ASCO Journal of Oncology Practice podcast. This is Dr. Bob Miller of Johns Hopkins and consultant editor for JOP. In this podcast, we're going to be discussing the topic of patient-reported symptoms in oncology care. And there are two articles of interest in the January 2011 issue of JOP. The first is original research from Daryl Bainbridge and colleagues at the Juravinski Cancer Center in Hamilton, Ontario. The paper is entitled Multidisciplinary Healthcare Professionals' Perceptions of the Use and Utility of a Symptom Assessment System for Oncology Patients. Also in the same issue is a commentary by Dr. Ethan Basch of Memorial and Dr. Amy Abernethy of Duke entitled Encouraging Clinicians to Incorporate Longitudinal Patient-Reported Symptoms in Routine Clinical Practice. I'm pleased to have both of the authors of the commentary as my guests for this podcast this evening. Dr. Basch is a medical oncologist and outcomes researcher at Memorial Sloan Kettering Cancer Center. In addition to his clinical focus on prostate cancer, he directs a research program aimed at developing new approaches to collecting symptom information in clinical trials and routine cancer care. He currently chairs the ASCO Clinical Practice Guidelines Committee. And welcome, Ethan.
Thank you. Nice to be here.
I'm also pleased to introduce Dr. Amy Abernethy, who is a medical oncologist and director of the Duke Cancer Care Research Program, which conducts clinical trials featuring the novel use of information technology for research, symptom assessment, patient education, and patient-provider communication. She's also responsible for the implementation of a large-scale electronic patient-reported data collection system at Duke for routine clinical care in the oncology clinic. And welcome to you, Amy.
Thank you very much, Bob. Nice to talk to you.
Let me start by asking Amy the exact question which you pose in your commentary in the article. Why don't physicians routinely and systematically use tools like questionnaires to elicit patient-reported symptoms and quality of life measures over time?
Well, the most basic answer is that we're not taught that way. When we think about the science of medicine and then we think about the art of medicine and what happens in the clinic, it's that time when you're talking to patients and when you're communicating and creating the therapeutic rapport with your patients that you learn about how they feel, the symptoms that they're experiencing, what their life is like. And we're not taught as physicians to substitute that with pieces of paper or surveys. Further, when most of us were training, it was at the same time that survey research and psychometrics and the development of reliable questionnaires was happening. And this information was both cumbersome to collect as well as not easy to input into the medical record. Fast forward, and we recognize that we need this information systematically, that at the end of the day, we can collect it, but not only can we collect it electronically, and that by having reliable information over time, physicians can make useful decisions. And I think that puts us in contemporary practice of 2011. So I think physicians haven't routinely done this, but they're now starting to look at the role of continuous symptom assessment using survey questionnaires as well as quality of life questionnaires in the clinic as a way of conducting our practice and understanding what's going on with our patients.
You say clinicians tend to underestimate the severity and prevalence of patients' symptoms and functional status problems. How much of an issue is this?
This really has been demonstrated to potentially be a major issue. There have been multiple studies directly comparing patient and clinician reporting of symptoms, and particularly symptoms relating toxicity in the setting of routine chemotherapy administration, finding that disagreement is common, and in cases of disagreement, clinicians tend to underestimate the severity of patients' symptoms. And the level of disagreement can be up to 60 or 70%, depending on the symptom one is looking at, but it tends to be a greater disagreement for highly subjective symptoms like fatigue or nausea. And the potential downstream implications of this is that issues that patients are experiencing may go unaddressed in the clinical setting.
So why do you think it is that physicians seem to prefer to assess patients' symptoms themselves? Is it hubris or paternalism, or is it just too much a part of their comfort zone to give it up?
Go back to that fundamental issue that we're not taught that way as physicians, to have patients report their symptoms somewhere other than within the context of the clinical visit. Also, as physicians, we're used to using that reporting to make other clinical judgments, whether that's to decide what we think is going on. So essentially creating a differential diagnosis or an assessment of a problem, as well as developing the plan. And so physicians are going to be reluctant to give that task up until they know that the information is reliable. Now, Ethan's just told you that, in fact, the information may indeed be more reliable and more appropriately assess severity and function when patients do report in a systematic way. But as physicians who haven't been taught that way, we're going to need to be convinced that this is going to be a reliable method that can be substituted into our practice.
Yeah, and I completely agree with that. I think there's a substantial cultural component here. It's just simply not something that we were taught to do. And there is a prevalent feeling amongst clinicians that we do have insights about the experiences of our patients, that we do understand what they're experiencing. And I think the burden is on researchers to demonstrate to the community at large that, in fact, there are a lot of experiences that patients have that unfortunately go unnoticed by us as clinicians. I would add to that there's a logistical component to this as well, which is patient self-reporting simply is not integrated into the workflow of how clinics function, and that's also a barrier. It's simply not the way that we do business. And so when a clinician begins practice and they come into it, they become comfortable with the workflow as it exists. And integrating patient reporting simply is not a part of the routine workflow. What we know from a number of settings where patient self-reporting has in fact been introduced into the workflow, clinicians, including both nurses and physicians, are actually quite comfortable with it and adapt to this approach quite readily.
Why do you think that is? Is it just a time issue that the physicians don't have enough time built into the visit structure?
Well, we've discovered at Duke, after implementing a large-scale review of systems, documentation using electronic systems, that we can actually improve practice efficiency and reduce the time it takes to see patients. But that takes a lot of learning. You have to figure out workflow. You got to figure out who's going to respond to what kind of symptom and when. And you also have to understand how the documentation reaches the medical record in a reliable and consistent way, and then how physicians are going to use it. So it takes a while for the practice efficiency to happen, and physicians have to be comfortable with that learning curve.
Let me ask Ethan about the role of nurses, because in the paper that's in this issue, there's a distinction made between the data that nurses collected and what physicians collected. It's been said that nurses are more likely than physicians to review and use patient-reported symptoms, and that maybe physicians perceive this to be more logically part of a nursing workflow. Do you think this is valid, or is this just an excuse that physicians are making?
I actually think it is valid. In work that we've done in this area, our observation has been that nurses much more readily embrace a patient self-reporting approach, because symptom management is in many practices within the realm of what nurses do more than what physicians do. Not that physicians aren't interested in symptoms and don't make management decisions around symptom control, but the nurses tend to be interfacing with the patients directly more frequently around symptoms. And this isn't just at visits, but also between visits. And so to me, it does make intuitive sense that this might fall more under nursing. One could also make cultural statements about physicians versus nurses, but it really hasn't been studied. It's more of an empirical observation at this point that nurses tend to accept this approach more readily than physicians.
We've learned in our clinical practice that there are different symptoms and different topics and concerns for patients. So that as practices get used to systematic symptom and quality of life reporting, then they can start to decide which provider takes care of which constellation of problems. So, for example, we have a workflow in place where nurses address a certain group of issues upfront before the patient even gets to see the physician. And it reduces the time the patient sees the physician because there's comfort both on the physician side as well as the patient side that those issues have been taken care of and that we do so in a systematic manner. But that is because we recognize the importance of the role of the nurses and highlight that upfront and talk about it upfront with patients.
That's absolutely right. And, the roles may differ from practice to practice. And so I think understanding how the patient voice plays a role in the workflow of the particular practice is very important.
I want to talk with both of you a little bit about the Bainbridge paper that's in this issue of JOP. So in this paper, it looked at the perceptions of physicians, nurses, and other healthcare professionals at the Juravinski Cancer Center, which is in Hamilton, and they use, I guess, it's a tool called the ESAS, the Edmonton Symptom Assessment System. Can you tell us, maybe Amy, you could tell us a little bit about what the ESAS tool is and how is it used?
Sure. So the ESAS is a survey instrument that was developed in Edmonton. It has 9 symptom items that are common in cancer, things like pain, shortness of breath, nausea, anxiety. And these items are answered on a series of 0 to 10 scales. It's been shown that you can use the ESAS even several times a day to follow symptoms over time for individuals. And what they did in the cancer centers in Ontario is that when patients came into the clinic, so this was done in the clinic setting, they either completed the ESAS on a kiosk, which was a computer sitting in a centralized setting, or by paper. And then that information was delivered to the clinical providers there in the clinic.
How would you compare the ESAS to the newer symptom screening tools like the Pro CTCAE instrument?
As Amy pointed out, the ESAS it's a brief survey that includes 9 discrete symptoms and asks about the severity of those symptoms. And it's a good general screening tool, but has a couple of limitations in this setting. The first is that there are only a limited number of symptoms that are represented, and there's not the ability for additional symptom items to be added for particular populations or by a clinician for particular patient or patient group, and also patients can't add additional symptoms to it. And so it may be limited. And Amy may want to comment on how this might have impact on issues such as billing in the United States.
When you think about the role of review of systems in the clinical visit, we use a review of systems to make sure that we haven't forgotten something. So it's a way of essentially going line by line or item by item and ensuring that all the patient concerns have been benchmarked as a part of the clinical visit. As a part of that, we then map that to billing. And so the coding for the clinical visit that is ultimately submitted to CMS is designated by how intensive the visit is, including a number of items addressed within a review of systems. So there's several pieces here. So first of all, it means that the review of systems that's done has to be complete enough to accomplish all of the tasks that the physician is trying to do. And frequently, 9 items doesn't cut it. Secondly, and ideally in most oncology practices, given the breadth of topics we need to cover, we'd like to make sure that it also maps to as high of a level for clinical visit billing is as justifiable for that visit, which is often quite high, and 9 items, again, cannot supplement for that kind of review of systems. So better survey instruments likely are those that accomplish the physician and nursing needs as well as the patient needs, and also map to practice efficiency and clinical billing indicators, which ultimately are the reality of clinical practice.
And so if you look at the ESAS, although it has 9 very common and important symptoms, and obviously I think Amy and I are both making the argument that it's a good thing to ask patients to answer these items, but it does miss other items that might be important in patients, particularly those receiving chemotherapy, like sensory neuropathy or diarrhea, or mucositis and so on. And so there's been a growing interest in developing instruments that have a broader constellation of symptoms available for the patient to self-report.
We should probably clarify that CTCAE stands for the NCI's Common Terminology Criteria for Adverse Events.
Yeah, Pro-CTCAE is an instrument that's been developed by the United States National Cancer Institute, and both Amy and I have been involved with its development. And this essentially is an adjunct to the CTCAE, which has become the standardized tool for clinician documentation of adverse events in oncology. And the Pro-CTCAE includes more than 80 different symptoms and looks at not just the severity of symptoms, but also the frequency of various symptoms and their impact on patients' activities of daily living. And what this tool does, obviously patients aren't asked to answer 80 questions at every visit, but it allows for specific items to be selected in any given context, which are particularly salient to that particular setting. And also patients can add additional symptoms onto it, giving a broader ability to detect the patient experience.
Recently, the FDA issued a guidance document indicating that for subjective experiences such as symptoms, patient reporting should be considered the standard approach for gathering information rather than clinician documentation. Is this just for the clinical trial setting, or is this part of routine care?
Yeah, well, the FDA did issue a guidance document about a year ago in final form that's really intended for the pharmaceutical industry to understand the FDA's thinking about patient-reported endpoints as they're used to demonstrate treatment benefit in the regulatory setting. So it really isn't focused on the routine care context, but has really had an impact more broadly because it's indicated that the FDA really does feel that the patient voice is important to express when understanding the impact of treatment. And so this really has created a dialogue around the optimal ways to collect patient-reported information in clinical care. And beyond that, it has also inspired a lot of thinking about how rigorous these instruments should be developed. And so to answer your question, the Pro-CTCAE developed by the NCI has been done within the framework of the FDA's guidance so that it does meet all of the methodologic criteria set out by the FDA.
I want to talk to Amy about the broader societal benefits of collecting longitudinal patient-reported information about symptoms. You make some reference to this in your commentary. Up to this point, we've generally been talking about the one-on-one clinical encounter, but I gather that there may be some applicability of collecting patient-reported symptoms to the concept of a rapid learning healthcare system. That's a little bit of an obscure concept, I think. Maybe you could tell us a little bit about rapid learning healthcare systems and where this fits in.
So really, as we think about the collection of patient-reported information, symptoms, quality of life, satisfaction, function, in a routine way in the clinic, there are two goals. One goal is to directly impact patient care right now. And we do know that there are near-term clinical outcomes that are positive, including improvement in patient satisfaction, symptom control, and quality of life when this is done in a routine way. But when we think in terms of looking towards the future and societal benefit, often we talk about what the Institute of Medicine has termed learning healthcare systems. Learning healthcare systems are essentially healthcare in a broader context whereby the clinic and clinical practice and research and development are better approximated so that the clinic informs best research and best research makes its way to the clinic faster. Another way to think about this is that it is the process that is enabled through continuously aggregating data so that the care of a particular patient today is informed by all the people who've come before her, and her care is then reintroduced into a growing pool of data so that we can better take care of people who look similar to her in the future. Well, where do PROs, or patient-reported outcomes, and patient-reported data fit into all of that? Well, so first of all, if we think about cancer, patient-reported outcomes data are a critical data set in all of this. This is the information that tells us how people experience their care, what their illness feels like, and how we can improve on that over time. And importantly, it's one of the few outcome points that is ephemeral. If we don't capture it at the time it happens, then we really can't go back and get it. It's very hard to go back and say, remind me, what was your quality of life like on June 6th, 2006? So we knew that information. Now, as that information is aggregated, it can be linked to data of all different kinds as the data systems for rapid learning healthcare start to take place. As I talk about this, I always imagine it's kind of like the blinking light concept, and I feel like we're talking about neural nets wrapped around the United States and the ability to identify the street lamp in Seattle. But there are some real near-term examples of how rapid learning is happening right now with patient-reported outcomes. And so let me give you a couple of these. First of all, as I mentioned, we have a process in place at Duke whereby patients who come through a number of our oncology clinics answer a full review of systems at every visit, very similar to what's happening in Ontario. And that information is then pooled and evaluated over time. We've learned that one of the top 5 symptoms that we didn't know anything about across our clinics is sexual distress. And that, in fact, it's one of the few symptoms that's flat. We had no education systems to deal with it. We really didn't have a lot of provider education. And we realized that we didn't have a lot of interventions at play either. So as a result, we were then able to take that information to our psychologists and neurologists and start to develop a system of care, then take that actually to the American Cancer Society and partner with them on a grant that was ultimately PI'd by a woman named Jenny Reese, who's now at Hopkins, to study new interventions. And then those interventions are actually directly re-embedded into electronic data processing systems so that we can understand whether or not the interventions improve sexual distress in the near term and then ultimately over time. Similarly, the same patient-reported outcomes data collection systems can be used to trigger patient education. So if a person comes into our clinic and reports that they've got insomnia that hits a specific threshold, then they automatically learn about non-pharmacological techniques to manage insomnia. If on the next visit the insomnia persists, then we step it up a bit and call in additional providers as needed, et cetera. So we're able to trigger patient education that's both non-pharmacological as well as pharmacological in a very systematic way. Thirdly, we now have automatic psychosocial triaging. So depending on the psychosocial distress scores of patients coming through our clinic, we can automatically determine and match them up with the best psychosocial care provider. But more importantly, in the same way that your computer and Pandora learns what music is best for you, we can start to better match up psychosocial care to patient groups over time by continuously applying adaptive learning models. And we're partnering with UNC right now to start to build those adaptive learning models directly into the system. So those are 3 examples, and I haven't even started to talk about how we use patient-reported outcomes linked to other data for evaluating novel therapeutics and other drugs and health service delivery models in the clinic, really making this process of rapid learning happen in real time.
Are you actually doing some of these things at Duke right now?
Yes, we have all the examples I've given you are in process right now. And we also have a number of case examples now of how we're using the same patient-reported outcomes data collection system that is providing a review of systems for our physician as a mechanism to study novel therapeutics over time. So, for example, 2 different drug regimens for prostate cancer and for many different points in the disease trajectory, trying to better understand what does symptoms look like, what does quality of life look like in an effectiveness population as opposed to in a clinical trials population.
Let me ask Ethan to sort of look into the future too. What do you think are the next steps for future research in this area?
Yeah, I think there are several areas, and Amy alluded to a number of them. One of them is to move into the between clinic setting, so that we can allow patients to report their experiences not just when they're at clinic, but between visits when they're out of sight and out of mind. Where currently, really, the pressure is on the patient to pick up the phone and call if there's something going on of concern, and this would really allow for a continuous monitoring of patient status. I think the second area that's of interest is one that we've been very involved with at Memorial Sloan Kettering, which is using patient-reported data to support clinical decisions in real time, similar to some of the areas that Amy described. For example, collecting patient-reported information that might inform a decision to hold chemotherapy or reduce a dose. The second would be in the phase 1 setting to determine an MTD or a DLT based on patient-reported outcomes. And the third is, again, similar to what Amy described, to use patient-reported data as part of prediction models to understand and risk stratify patients towards one treatment or another, much as we've used in a very rudimentary way to decide, for example, in patients with metastatic lung cancer, whether or not chemotherapy would be beneficial based upon baseline performance status, to use a more nuanced multi-symptom longitudinal approach to understand who may or may not respond well to treatment. I think the final area that will be very interesting moving forward is around integration with electronic health records and electronic medical records, allowing patients to track their own symptoms, allowing this information to be fully integrated with the EHR and to be delivered to clinicians in real time in order to allow them to better manage symptoms and allow them to better document this information. So it's a very exciting area, and a lot of the innovations in technology and progress in EHRs has allowed us to move a lot of this work forward that previously would have probably been too logistically cumbersome to achieve.
I was waiting for someone to mention PHRs, so it sounds like that's sort of what you're getting at, as a personal health record model, at least.
Absolutely. There are multiple private companies now that have applications on the web and for portable devices that allow patients to self-track their own symptoms. And there are a number of widely popular online communities. The most widely recognized one is Patients Like Me, but there are multiple ones, including cancer-specific ones, that allow patients to exchange information with each other about their symptom experiences. And these websites have actually aggregated patient symptom information so that patients can benchmark their own symptom experiences with other patients who are similar to them. So patients are already doing this. So it makes sense that we as clinicians would capitalize on patient interest and willingness to self-report this information and actually use it to better the treatment experiences of our patients.
One of the other things that goes along with the ability of patients to self-describe, but also then to help direct personalization of their care, is that the use of patient-reported outcomes data, when the data are reliable, and I underscore that point, means that we really can start practicing with near-term healthcare personalization and personalized medicine models. We don't have to wait for another decade of new technologies and prices of microarrays to come down in order for us to start to understand what does it look like to put real multivariable models into play in the clinic using electronic health records and multiple symptom items and other linked data, including clinical, demographic, and tumor-based parameters. So this gives us the opportunity to essentially use patient-reported outcomes as a part of the learning process so that as more and more technologies become available to us, we're ready to know how to use them, not only in terms of how to do the mathematical models, but actually how to put clinical decision support into our workflow, how to make sense of it, how to communicate with our patients about it, et cetera. So there's lots of points along the rapid learning highway that we've got to figure out. And patient-reported outcomes help us do that now as opposed to waiting to the future.
Yeah, I think that's absolutely right. And as we think about these various types of data, one of the things that's been recognized is that different data sources are appropriate for different kinds of data. We rely on the laboratory for laboratory data. We rely on a radiologist to read images, and patients are in the best position to convey their subjective experience. And what an abundance of information has demonstrated is that no person can really understand the experience of another person with great reliability. And so it makes sense as we think about developing these models, especially models that are valid and reliable, that we use the best data source possible for the information that we need to obtain. And for symptom information, that data source is the patient, him or herself.
Well, it sounds like this is a form of personalized medicine that is a lot more available and a lot less expensive than if we were focusing only on genomics.
Exactly.
Dr. Basch and Dr. Abernethy, I want to thank you very much for taking the time to talk to me tonight. And I want to encourage our listeners to take a look at the entire issue of the January Journal of Oncology Practice for some additional great articles about a variety of practice-related topics. If you're an ASCO member, you should be receiving your copy in the mail shortly, and you can read all of the articles online at jop.ascopubs.org. And we would love to hear from you, so please let us know what you think about these new JOP podcasts by sending comments and suggestions to jopeditorsdesk@asco.org. And if you've not discovered it yet, these podcasts are available on iTunes now for even easier downloading. This is Dr. Bob Miller for the American Society of Clinical Oncology. Happy New Year, and thank you very much for listening.